Next slide. So basically, up until recently, there were only two types of vaccination. There was the live vaccination, and there was an inactivated virus or a toxoid vaccination. The live one, we've always known as rubella and varicella. The inactive ones are Tdap and influenza. And now we have an mRNA or a vector vaccination, and an example of that is COVID. Next slide. So in pregnancy, in general, live vaccinations are usually contraindicated. And the reason it's contraindicated is because a live vaccination, while it's attenuated, can convert to a wild type and therefore cause the disease. An inactivated vaccination or toxoid is considered safe, and the mRNA vaccinations are considered safe in pregnancy. So the vaccinations we should do every pregnancy is the Tdap. Ideally, we would give it around 28 to 30 weeks, and we recommend it every pregnancy, not because the mother needs it, but because of the pertussis in the Tdap. It causes an immunogenic response, and the mother produces immunoglobulin that crosses the placenta. And the baby can't get to pertussis until I think about 6 months of age. And this is basically the only protection the baby has from a pertussis or whooping cough. So we give that to the mother every pregnancy, but the cocoon, the people around it, the grandparents, the people who take care of the baby during the day if the mother works, they only have to have the vaccination once every 10 years. Influenza, we give yearly. And we all know that women aren't a candidate for the live attenuated intranasal vaccination because, again, it can convert to the wild type. Next slide. Vaccinations that aren't indicated in pregnancy, again, is rubella, varicella, HPV. If a teenager is getting the series, do not continue it during pregnancy. The reason is that we simply don't have the safety data for this vaccination. Zoster is another recombinant DNA vaccination. It goes by Shingrix. It's not recommended in pregnancy because, again, we don't have safety data. So if you give rubella, somebody seeks preconception counseling, or varicella, we usually tell them to wait 3 months prior to getting pregnant. But some other sources will say 28 days. Now, you always hear rubella can cause rubella syndrome in the baby, with deafness and issues. But I don't think there's ever been a case where the vaccination in and of itself caused a problem during pregnancy. If there was, the person got one and then got pregnant. Next slide. So the COVID vaccination, we've all learned about that. It is safe in pregnancy. The booster is recommended, and all of y'all probably know that there is a new booster that is out now. It's been out about a month that covers Omicron. And so if it has been greater than 2 months since the last vaccination, the Omicron booster is recommended in pregnancy. Now, one of the misconceptions about COVID vaccination is you can take the vaccination after you get COVID. You don't have to wait a certain amount of time. It's only if you get the immunoglobulin that you need to wait 90 days. This is the CDC website that actually talks about the precautions during pregnancy and stuff. And so it's updated. So I put it in the presentation so any of y'all could go to it and look at it. Next slide, please. And I don't know, there are resources available to patients. I got this directly from the CDC website. And it gives you a number that the patients can call. And there is mother to baby that they can go to and send an email or chat live. And if you go, where you can find this is on the prior website that I gave you on the last slide. So that may be a good resource for your patients. Next slide. So I put this in because we're constantly asked by our 18-year-old niece or nephew, which vaccine should I get? Or our 48-year-old diabetic friend, or our 36-year-old neighbor with Crohn's disease. This is actually another website that you can go to. And when you click on getting your COVID-19 vaccine, it actually asks you a series of questions and tells you whether or not you should get the vaccine. I didn't go through each of these things because these people aren't pregnant, but as healthcare providers, we're constantly asked, so I thought it would be a useful resource for people. Next slide. So, of course, now we've got the monkeypox and we're getting monkeypox questions, and it's only going to be a matter of time before we start seeing it in pregnancy. Now, Eric, if you can tell me how to say these two names of these vaccinations, I would be greatly appreciative, but I don't know how to say either one of them. So I'm going to just tell you the one that begins with the J and the one that begins with the A. So there is the monkeypox vaccination available, and both of them are live viruses. So the one that begins with a J is live, but it's a non-viral, it's non-replicating viral vaccine. But the one that begins with A, ACAM 2000, is a replicating viral vaccination. Both of these can be given to prevent monkeypox, or they can be given as a post-exposure prophylaxis. Like your husband gets monkeypox and y'all slept together for the last couple of weeks. If he's been diagnosed and there is a pregnant woman who needs post-exposure prophylaxis, then we should use the live non-replicating viral vaccination and not the replicating viral vaccination. So it should be shared decision-making because we don't know yet about monkeypox in pregnancy. And so we don't know what adverse outcomes come from monkeypox and pregnancy. But with shared decision-making, if y'all feel that vaccination is necessary, then I would give the one that begins with the J. Next slide. So there's some unusual vaccinations that we're asked about during pregnancy. One is yellow fever. Yellow fever, I don't know how much you know about this vaccination, but it is a live vaccination. And in fact, when you take the vaccination, there's about a 1 in 250,000 chances that you will actually die from the vaccination itself. It's not recommended for people with immunocompromised who are greater than 65 years of age, because it's recommended that if you're at increased risk from dying for the vaccination, you probably should not be going into an endemic area for yellow fever. If you get yellow fever, even very young people, the risk of death is 20 to 50%. And so if a pregnant woman has to go into a yellow fever pronged area, the vaccination is definitely safer than getting yellow fever. And so that is why it's recommended. Rabies is an inactive vaccination. And if someone needs a rabies vaccination, it is recommended for post-exposure prophylaxis. It is not recommended in pregnancy for pre-exposure prophylaxis because we don't have much data. You can also give hepatitis A and B during pregnancy because they are both inactivated. Now, meningococcal vaccination, there's 2 different types. And if you're giving a meningococcal vaccination, I'd probably consult an internal medicine doctor or actually a pharmacist. There's one that's considered safe, and the other one recommends that you defer until after pregnancy. And again, the indications for the 2 vaccinations are different. So I didn't go into details here, but just know you need to know which vaccination you're given and that they're for different indications. Next slide, please. Polio, as you know, that there is a resurgence of polio. It's now in the New York City water. And so, and if you're going to an endemic area with polio, there's 2 types of vaccination. There's the oral, which is a live attenuated vaccination, and then there's an inactivated shot. And so you would be recommended to get the inactivated shot. Typhoid can also be given. And anthrax, we have very little data on the anthrax vaccination, so it's not recommended for pre-exposure prophylaxis, but it can be given for post-exposure prophylaxis because of how deadly it is. Next slide. So immunocompromised individuals have a different recommended vaccination schedule than people who aren't immunocompromised. They're recommended to have the pneumococcal, the Haemophilus influenza, and the meningococcal vaccination. Now, immunocompromised individuals are people who've been treated for cancer, people who've had organ transplants, people who have sickle cell disease and are asplenia. And most of these individuals come to us vaccinated. And so we don't have to think about it. But if they don't, then this is a website you can go to that will tell you whether or not it's safe in pregnancy or where to wait until after pregnancy for it. Next slide. Now, in the postpartum period, it's almost a reflex if somebody is non-immune in rubella to write the MMR, or we can give the varicella. But the one thing we really need to remember, and this just happened in our practice that made me think about it, is rubella is a live attenuated virus, and therefore you really should not give it to immunocompromised individuals, like patients who are on immunomodulating drugs for rheumatoid arthritis or for Crohn's disease, that type of stuff. And so just remember that, so that the patient doesn't have a case of rubella with a new baby. So that is all that I had prepared for today. So